Welcome to yet another special broadcast for Budget 2021. This is the roundtable conversation we're going to have. Like I promised you on Monday, through this week, we intend to pick up different topics and break them down to try and explain to you what it is that you can expect from the budget. Now, these are not the usual technical issues about sectors and economy, but we're going to talk about issues that matter to you and impact your life, and how budget is actually not a very alien, strange concept, but really can impact your life in many ways. Honestly speaking, everybody knows that India's healthcare is in an abysmal state, and it's been like that forever, for decades now. Since I have grown up, across the cities that I've traveled, I've seen the same state of affairs. But what the pandemic year did was put the spotlight on it. It really showed that we weren't that great even in our cities. We weren't that better off even in our best of and the biggest of our cities. And of course, the rural status and the state of affairs was astounding and horrifying. So can we use this opportunity? After having gone through the COVID year, can we use this opportunity to fix some of these issues, to recognize that healthcare is a very important part of our life and the government has an extremely important part to play? And can we expect Finance Minister Nirmala Sitharaman to come up with some kinds of announcements to boost India's healthcare sector? It could be as simple as the primary healthcare centers. It could be as simple as saying, let's ensure that there are more schools and colleges and universities that really train people for the healthcare sector. It could be about health insurance. How much do you know about that? How many of us actually have a proper health insurance in our lives and for our family members? It could also be about the number of staff, doctors, nurses, ambulances available. So there is so much to cover. We're going to try and fix it all in this 1 hour, but I've got special guests joining us. I'm going to start by saying good evening to Vinay Tiwari, our managing editor, who feels very, very strongly about this issue. And, over the past 1 year, of course, we've discussed and debated a lot of the problems that exist, and we are hoping some of those do get addressed, Vinay. Let's also say hello to Avni Raja, regular face on Mirror Now, and Avni is also going to give us insight apart from the overall picture, specifically into insurance. That's Avni's forte, and she's going to try and convince some of us why it is important if we already don't know, and how to go about it, and what is it that the government can do to really increase the insurance penetration. One of the finest names when it comes to healthcare journalism and pharma journalism is Vikas Dandekar, and I've, as a cub reporter, grown up learning from him, and I'm super happy and glad about the fact that he's here with us, and he will help us understand the sector, the nuances of it, and the role that the government can play. Sure. And always a pleasure to have Anupriya Badunair with us, senior journalist. Anupriya has a huge amount of experience across the sectors, and we're going to be talking healthcare today, but Anu is with us for the week across the topics that we're going to be speaking about. So let's just first talk about the overall attitude, Vinay. And I think the first sign of that is the allocation that the budget gives to healthcare. It's abysmal. It's not even 2% of our GDP year after year, and it's not something new.
Yes, and I think one of the few things that we can be thankful about for the pandemic is the fact that the problem was always there, but it allowed us to now notice it and feel it very personally. Possibly every family ended up feeling it in some way or the other. Because remember, not only do the families who contracted COVID had to deal with it, but even those who had some other ailment had to suffer because the system just squeezed the other people out. So this is something that impacts and touches everyone, and that's why we're spending an hour on it. As you said, we are 10th in the queue in terms of the budgetary allocations. 1.5% is all we allocate. And we've been arguing on Mirror Now, at least for the longest time, that this allocation needs to maybe triple itself, if not certainly be more than that. Because Indian healthcare suffers from an affordability problem, it suffers from an access problem, it suffers from a footprint problem, and it suffers from a quality problem. So virtually every single problem that you can imagine exists.
Yes.
And that's
from
why...
From the bottom to the top.
From the bottom to the top.
From all kinds of services.
Absolutely.
So that is why it is extremely important that we talk about and see where do we start fixing it from. And Anupriya, of course, we know every year if we see that about 1.5 or 1.8% of the GDP is allocated. But again, it comes back to the conversation, how much of that is even used by the end of the year?
Actually, those figures make very little sense to anybody who's hearing it. 1.5% of GDP, 1.8% of GDP. I mean, it really only tracks the ticker headline, so as to speak, on budget day. I think if you want to see how much of it actually is being spent, and I think Vikas can talk a little bit more on that, I was looking at some numbers, and I think India spends close to only about 1,800 rupees per person is the spend on, which has gone up from about 1,000 rupees a person over the last decade. So the incremental move on healthcare has been very little. If you look at the percentage, Tanvi, and you all have all of these graphics that you will talk about through the show as well, most of these increments have been because of pay hikes. They've not been because of infrastructure has been built in. Well-deserved pay hikes. Nobody is at this point arguing that you should not have a well-staffed, well-paid medical professional society there. But these are not gone into infrastructure building at all.
You're saying that the staff gets paid, the doctors and the nurses are probably getting paid better today than earlier.
Not getting paid better. They just have to
increase
a certain amount of pay. I mean, it's the pay commission. There are pay scales which have to be hiked.
Yeah.
And
keep in line with
to
inflation.
keep in line with inflation.
Yeah.
So nobody at this point is saying that
not
doctors
grudging
are getting
that.
paid well by the government also. I mean, I would like to reiterate that physicians or nurses or our primary healthcare workers are getting paid or what they deserve, but it's not going towards infrastructure, if I'm right, Vikas, right?
Yeah, so all the points that you all touched upon are so imperative to discuss right now. I mean, I was just checking about the BRICS countries, which are comparable. India stands last. Even China has 5% spending of their GDP.
Brazil has
so
9%.
Brazil is 9%.
Yes, 9%.
Russia is 5% again. South Africa has 8%. In fact, all the other low-income countries also, Nepal, Bangladesh, Sri Lanka, they have better healthcare systems. So that's a kind of a wake-up call on where we stand. And of course, as Vinay also mentioned, with the pandemic coming, a lot of these weak points have actually been exposed.
Yeah.
And what better could be the opportunity to make this budget a significant one from the healthcare angle? I think this should be the budget for healthcare.
We often, back at home, joke about it that when we get older and health issues become a big part of our lives, perhaps it's just prudent to shift to another country where, whether it's the West or even on the East, wherever you look, their healthcare system is so good and so strong, and they give that kind of value to it. We don't. How many of us even talk about it as an election issue, Vinay, or otherwise in our lives?
We know of people who would move to Canada and taken a PR for their parents, primarily
Exactly for
because
this
of health
reason.
issues.
Can I put a
Primarily.
dampener on what you just said?
Yes.
Do you know India has the world's highest number of below 35 years of population?
Yeah.
Yes.
Almost 60% of us.
Yes.
And we also have one of the highest levels of non-communicable disease load factor in that. So it's not just about now getting old anymore. You could contract a
could
very
be
serious
contracting it
costly
right away.
ailment even when you're much younger.
Right.
And that numbers are just growing.
But one important factor here is that because the age is on the lower side, we probably got saved from being extremely badly hit by the pandemic.
Yes.
Which is what Italy felt because
exactly.
the age dynamic did not
that
work.
Lombardy area had maximum.
But we were also lucky that it was a large part of this problem was restricted to tier 1, tier 2, maybe even tier 3 cities. The numbers in India were not so bad, or maybe we didn't get reported as much, but the rural, at least in Maharashtra, I know for a fact, as a lot of the home workers went back, they were made to quarantine outside before entering their villages. So they were kind of more sanguine about it, and that actually was the saving grace, because had it gone to the deep root of rural India,
it would have been a disaster.
the backbone of the healthcare system would have collapsed, completely collapsed.
Yeah, in fact, Avni, we've done so many of those stories in the last 1 year. We've dedicated ourselves to talk about healthcare in the pandemic times. And the cities, what actually came through in the pandemic year was, it's not just to say that your towns or small villages don't have access. The cities are not prepared. We can see that there are 5 flashy private hospitals that we can go to, but they're not prepared to handle the kind of the population that lives there.
Yeah, absolutely. And we've covered all of that, but let's just, step away from the numbers and see what the pandemic has put the spotlight on. Things like lack of ambulances.
Correct.
Things like not enough, staff in the hospitals, things like the paramedics or the nurses, all of those kind of things, the testing, ventilator beds, oxygenated beds, all of these things, they were clearly not enough. And let's remember, we've been extremely lucky that we haven't got that second wave the way other countries had, because if that happened, and we already saw in the first wave the kind of pressure that our hospitals were under, if the second wave actually happened, it would have been a complete disaster. I mean, touch wood, it doesn't happen. But this is really where the crux of it all, the kind of differences that we've seen across the board in the country.
Absolutely.
But I just want to throw in a point here that though at the time that we were looking at the pandemic, we were also seeing a lot of reports coming out that your regular routine problems just got completely sidelined. I mean, you're saying that for 1 year, the people didn't have kidney problems. There were no proper dialysis centers set up. I personally know of people that suffered terribly because they couldn't go for chemotherapy sessions, they couldn't go for their regular dialysis. And these are problems that are continuing. The pandemic hopefully will come and now go. But these are regular infrastructure problems that have been in our face for much longer than the pandemic, and they do need to be addressed.
So let's start off with what can be done in the budget and what can we expect, Vikas. And let's start with the infrastructure part of it.
Yeah. Yeah, so firstly, immunization. I think that has actually taken us back by a few years. TB is expected to really go up significantly. I think it will have to work on 2 tracks.
TB had already begun to become a problem before the COVID happened to us.
Absolutely. And now because there will be a vaccination issue of kids not getting vaccinations in time, I think that will look at a fresh surge again. So I think on one track, we'll have to kind of do the damage control so that immunization process can start. And then, you know, a lot of data which has got thrown up from this National Family Health Survey about nutrition. And you don't want to have an economy growing at 10 or 11% and at the same time having an issue of nutrition. Child stunting is a big issue. When will we think about that? I mean, mental health was never a problem, you know, as was perceived. Now it has become a big issue. So all of these things will have to be seen. I think, you know, I mean, from the days when we actually used to see budget and used to kind of wait to hear that, you know, there will be some mention of healthcare. It has come a long way, but hopefully it will really find a very strong position in this.
But with right now COVID being the focus and the vaccination drive being the focus, can we expect the government to come up with anything additional beyond, I mean, and of course, there is an expectation that there will be a vaccine cess that we may have to end up paying because the government needs the money to do this. But beyond that, do they have the bandwidth this year to start off something big and new?
So hopefully infrastructure will find a big place because rural healthcare, I mean, had it not really, had it gone to that stage, it would have been terrifying. So hopefully primary health centers will get fresh leaves. I think there was a viability gap fund which was spoken about last budget. I don't know where it actually stands right now, so we don't know about that. Jan Aushadhi stores where they actually made a promise that 2,000 new medicines will be made available. We have no idea. It actually looked like it's fizzling out. So there are some very good schemes which has not been developed in the way. You know, it's not about announcements.
Correct.
It's about really execution, and which is where we are failing.
Yeah, the other thing also is the digital part of it, you know, telemedicine, all of this, these aspects, if the government decides to push all of that, the remote areas, the rural areas, that can all start becoming more inclusive. So I think that is the other area where that big push has to come.
But look where we are coming from. We are coming from a place where in many parts, the primary healthcare centers are locked up. There is nobody there. We daily get these stories from different parts of the country where, you know, I remember this one story where a man's carrying his mother who's just met with an accident and he's kept her at the entrance door and he's running around the building trying to figure if there is anybody. From that to visuals of animals inside, you know, animals who themselves are extremely unhygienic, infested with diseases, roaming around, sitting on the bed. This has become a regular part of our lives.
And that's why Vikas covered most of the things that are critical for me. The one thing that I'm looking for, I'm not sure how hopeful I should be, but I want innovation in 2 things. Number one, it's a mistake to look at healthcare as a Ministry of Health issue. It's a Jal Shakti Ministry issue. It's a women and child welfare issue. It's even a roadway transport and highways issue.
It's part of the
education.
And the government, and I'm hoping they're listening to the experts, there is a burden on the government. Simply see what happens in states like UP and Bihar. The number of patients who reach in a terminal state in hospitals is so high. It's a burden even for that reason. There's a cost burden that you incur when a patient reaches in a terminal condition in a hospital. That is there because the primary health, the early detection concept, which should have been there because of a good private sector, is just not there.
Correct.
I mean, in Darbhanga, for instance, the district hospital is serving 6 districts around it. It is unimaginable. You really cannot have a situation like this. And that's possibly one reason why states like Kerala tend to respond better to, they had a massive flood and you see that there was no outbreak of an epidemic after that. In Bihar, the same problem doesn't get tackled so easily. In Eastern UP, every year there are animal diseases because the detection is very low. And even if it is, because the cost of transporting the patient to the center is so high, people are reluctant. They just don't go to a doctor. So I hope the government sees it as a multi-ministry issue and not just a health ministry issue because it's interlinked.
But I'm still stuck on that point that Tanvi brought up. But what can they really do? Will they come out like they do for education, announce, they announce 10 more IITs, 5 more IIMs?
Yeah.
Will they do the same this time? Will they just come out and say,
5
okay,
more
we're going to
aims,
have
10 more aims.
We're going to
Makes
have
sense
one aim in
actually,
every state. I mean, on the sound of it, it sounds fantastic.
Yeah.
Oh, there's going to be aims in every. But look at a state like Maharashtra. What is one aims going to do?
That's true. Yeah.
So, I mean, I am still, and maybe Vikas can help us, but I'm still battling to understand that where does the first foot forward really even come from? And mind it, when I was going through and trying to prep myself to sit next to Vikas and talk about healthcare.
No, come on.
And disclosure, I haven't got my 10-year-old vaccinated this time around for a booster because I was too petrified to take her in for a vaccination shot.
Yeah.
But I mean, you come to a point where you're wondering what can the government really do? If they set up more hospitals, are there really doctors who are willing to work? 80% of the burden is onto private hospitals that are not even taking 10% of the critical patients at this point.
Yeah.
So I have one answer to that. I mean, of course, I don't have the answer which the government will have, but I'll have one answer. You see, health infrastructure is as much a state government issue as it is a central government issue.
So public sanitation, what I understand, comes under the state
Yes,
list.
and not even health. I mean, it's a concurrently subject, right? Now, the thing is, the central government either needs to shed some bit of the big brother, that I give you Dole's mindset, or the arrogance that, you see, I am the center and I decide everything for you. You really need a little more partnership going between state and center, because if you see the spends the states, that adds up to much more than what the central government allocates. It's about 68,000 crores is what they allocate.
69,000.
But the state governments, if you add all of that, it will be probably 1.5 crore, which is way more than what the
You're
central
really
government
hoping for a new India, better
yes.
action between states.
That's our branding. A new India is our
If
branding.
this doesn't teach us to do that, what else will, right?
It's our budget programming's branding. That's how much we are hoping for a new beginning after the year we have gone through. Okay, so like Anupriya said, Vikas, one part is, of course, the infrastructure. And like, maybe a little more can be expected on the primary healthcare center front, the PHCs, covering up the gap which we already have. The second part is now, what do you do with those buildings?
Exactly.
In our country, if I'm not wrong, we have what? One doctor for 11,000. In some states, that ratio gets
5 per
further skewed.
10,000. Yeah, that's
28,000 people and one doctor in Bihar.
It was 8 to 10,000.
8 hospital beds for 10,000.
And 8 doctors. 8 hospital beds and 8
Exactly.
doctors to 10,000.
Yes, so,
That's the
and
last
that is
figure.
not a problem you can fix quickly.
No.
You will need time to set up the educational institutes, then time to train and teach these people.
Exactly.
I mean, in my limited understanding, it looks like a 10-year process. And what do we do in the meantime?
So basically what has happened is that there is such a massive asymmetry of allocating resources at the right places. Even now the government is actually struggling by putting, so many conditions that, okay, after you finish your medical education, you have to get transferred, you have to be posted in rural areas. And then in desperation, what they are doing is they are actually doing these cross therapies. Homeopaths will have to be given allopathic, treatment and all these things. So point is that if you build institutions, I mean, AIIMS, I am told that many of these specializations are actually not available in AIIMS. You may have all these AIIMS in all over the country, but do we have can any of these AIIMS be a match for the AIIMS in Delhi? They wouldn't be.
Yeah.
So that's where the whole effort of skill building comes in. And Dr. Devi Shetty has been in most of the forums, he's been saying that, okay, when do we actually train up our paramedics? When can our nurses actually become eligible to manage those primary healthcare issues?
So there is one question that I probably had to Vikas, which is this, that for me, one of the possible innovations is, actually it's a great idea, provided it's implemented properly, because it solves typical Indian problems. And that is the National Digital Health Mission. And I'll tell you why. That solves the hesitation that people have in traveling long distances, which is an expense for them, and seeking even basic care, which can lead to early prevention. I mean, in our office, there are cases where people have flown multiple hundred thousands of kilometers to seek basic health care. Now, there are smaller problems that people have for which they still have to travel long distances, which is an expense. telemedicine or digital medicine can actually bring that down. I mean, you can reduce that cost and allow people to access formal healthcare, not the Ojha or the Baba that they
But
probably go to.
you would still have the same doctor catering
That
to
is true.
28,000
That is
people.
true. Which is why I
But
say
more
that it is not.
efficiently. But more efficiently.
But
I
it's
mean,
probably more
if you're looking at that viability gap of 10 years that you're talking about, that on one hand you start training people, but you do this. But my issue with that again comes. I mean, it's a fantastic plan on paper. My issue comes back to awareness.
Yeah.
You know, they announce a lot of things, but it doesn't get off the ground. So insurance as well, and Avni will obviously talk a lot about that later. But insurance as well, they announce the schemes and everybody is eligible for it. How many people do we actually know within our house help? I mean, I'm not even talking about, you know, people who can afford healthcare on their own and not doing it, but even on that, how many are actually availing those benefits from the government? Very, very few at this point.
Yeah, so 1.5 crores have availed Ayushman Bharat. That's about it.
Right.
Yeah, which is nothing. Which is nothing when you talk about percentages.
The 10 crore target, I think.
Yes.
Yeah, so that's 1% of their target and like 1% of the entire population.
So I will
on
come to
side.
that in just a bit because we were talking about this filling this 10-year gap, and you refer to the fact that the government has come out with a lot of policies which say that okay, let's put doctors from other streams on par with the allopathic doctors.
Exactly.
Give them a bridge course and say that okay, now you can also do these procedures. How is that really working out? Is it working? Because we saw a lot of resistance, obviously, from the allopathic doctors about it.
So, you know, these cross therapies are not acceptable because you may end up having a lot of malpractices coming in. You know, in a country like India, you have quackery all over the place. And who is going to misuse it? I mean, do we have the regulations? Again, one more very big factor is about transparency of regulations. I mean, if we really see an enforcement agency or a surveillance actually happening in the right sense of the word, then all of these notions, you know, if this is working or not, it will actually go away. But, you know, even in very critical decisions like these vaccine approvals, how much of it was actually made known before the final decision was taken? We don't know. It's all guesswork. So if you have a system which is really, you know, there is adequate surveillance, there is adequate enforcement, the FDAs are doing their job of actually nabbing the culprits, I mean, all of these will go away. I think it's also to do with this. So, you know, the relevance of budget comes when actually you see that, okay, what happened last year, the announcements that were made last year, has been done in such and such manner. We don't see that. Do we see, you know, 2 days later we will see economic survey, we will see the data. A week later we will all forget about it. So that's what, I mean, I think there is a lack of follow-up. And again, I'm sorry, I'm actually repeating this again, there couldn't be a better opportunity than this. We have been lucky that, you know, the pandemic actually went and it's showing a downward curve now. But look at countries with 16.9% health budget of the GDP in US. They're struggling.
They're struggling.
I mean, imagine if some invisible factors had not come in, what would have happened here?
So I think so much can be done in the existing infrastructure. I mean, so many hospitals are there across the country which are in absolutely abysmal state. Instead of just doing these band-aid solutions and trying to fix, you really put in money and fix them ground up, like from the root. And that will also add a lot instead of always trying to build new hospitals. Focus a little bit on what's there already.
Exactly.
Which I think then ties back to the point that Vinay was making, then there has to be a state role there. The states also have to ensure that the hospitals that are state-run are equally pushed.
Yeah, absolutely. Look, I know it gets the goat of a lot of people who are probably, you know, currently in the ruling dispensation, but the fact is that the Mohalla clinic example, which is easier to implement in Delhi, I must say this, it's not so easy in other states, is not a bad idea because it's a low investment, low cost accessibility issue. And the very simple logic is even in a city like Delhi, where, you know, I spent many years, I can tell you, in places like Yamuna Pushta, for instance, every lane will have 5 quacks, which Vikas was referring to. In Haryana, for instance, the default is not to go to an orthopedic surgeon. There are these wrestlers who also run bone-fixing clinics. It's very common there, and every district will have 10 of them. That's how our primary healthcare system is. It's run by the unorganized sector. It's the SME of Indian health sector. So, I mean, what's the solution for that? It's possibly upgrading what you already have, and also cutting out some of the roadblocks that you have because of a very complicated administrative structure we have. You have a civic body handling 5 hospitals, and you have a state government handling 5 hospitals, and you have another central government hospital. there is no match. It's not looked upon as a cohesive healthcare idea.
Remember what happened with Ayushman Bharat? Initial stages when this was all getting fixed and all, most of the states were saying we are not going to take it.
part.
You know,
They
so
didn't want it.
one
Yes.
after another they actually started dismissing it,
Yeah.
and then it took so long, you know, to bring them all on the same platform.
Yeah, but some of those states already have their existing
Yeah, so then
insurance
it
schemes.
took them some time to merge
To
the
merge
schemes.
the two.
Exactly.
Yes.
Yeah.
But we, again, because Ayushman Bharat scheme was announced two years ago.
Yeah.
The first allocation was just about 3,500 crore rupees.
yeah.
Then the last year, I think government stepped it up to.
I think it was 11,000, 6,000, then it came to about
further
11.
up, yeah.
Yes, but again, Anupriya, those numbers may or may not matter at this point because of the pandemic, and we don't know what got implemented to what extent.
So implementation across the board has been weak. It made me start to think about what happens to existing programs for, say, government employees, CGHS. It's a fairly successful program. I mean, as someone who comes from a family who is from the government services and is able to avail it till date, and we've had more and more private hospitals are. I think a lot of part of it comes down to being affordable as well.
Yes.
Yes.
Affordability. Though India is a medical destination, medical tourism is a big thing in India. I mean, the number of people that come in here for heart issues, for everything, because it's so much cheaper than getting it done anywhere else in some of these developed
But it's not
nations.
cheaper for us.
But it's not,
cheap
because
for
the
us.
currency works against
Yes.
us. So if
Yes.
you were
Yes.
earning in dollars, I mean,
I was
what's really
about to crib about a lot of labeling that is the bane of Indian healthcare sector. I tell you.
Medical
One
tourism.
label is medical tourism. Second label is pharmacy to the world. It's completely
Absolutely.
distracting you from the real problem.
Because we
Very
again
true.
don't get all those medicines
That's
at those
not the
costs.
issue. That's not the issue. No?
Okay,
But,
yeah, finish.
but I know for a fact that even private practitioners are saying that medical devices, and I mean, to the best of my understanding, still attract an 18% GST,
That's
for
right.
example.
Even
And
insurance
today,
does.
even
Health
insurance.
insurance,
Yeah.
Even health insurance.
Avni's insurance. But to be very honest, I mean, it's unthinkable for a country like India, where you're desperate for technologies to make systems more efficient, more X-ray machines, more everything.
Yeah.
And you're
But medical
asking,
devices falls under the PLI scheme also now. So hopefully that is at least
Tell the
some.
viewers what PLI scheme is. That's about
we did it
simplification.
last time. So if you watched on Monday, you watched us on
What is
Monday,
this?
you know what it is.
Quiz the viewer segment. Do you remember what production-linked incentives were? Which is where if you produce certain
again,
amount,
it's a
you get
very-
government support.
It's a very difficult thing to administer in a healthcare system. I mean, the benefits of the healthcare system may not be as easy as production in a two-wheeler factory, for example.
Yeah.
So you can't manage that, and so it's actually very. I mean, they have to really rethink about digital pickup for all of these hospitals, getting your records, digital records. I know there are a lot of the lower strata complaints that they have to carry these files every time because there is no digital record of people. Even if
But
they
you're
go to
saying
the same
that we
doctor.
already have a very good existing
CGHS, for
insurance
example.
scheme for the government officials. We just have to
They just have to
ensure
roll
that
it.
we broad base it,
Exactly.
isn't it?
That's it. Absolutely. So, honestly speaking, these schemes are really the ones which can actually hold as the best format.
Yeah.
And then the rest of the things. So one of the things that about Ayushman Bharat is also about private hospitals in the initial stages were not ready to get enrolled.
Yes.
Because they were saying that okay, the rates are going to be so low. But
Yeah.
that actually exposes the asymmetry. A doctor was actually telling me, a cancer specialist, saying, I thought that it will be easier for a patient to come from Nasik to Bombay because I thought that the rates will be lower. On the first day that he actually landed up here in Bombay for his treatment on chemotherapy and all, 89,000 rupees was the first day treatment, 89,000 rupees. And these are the things that actually do not go well when you actually said these labeling issues. Yeah. And we think that it's a low cost and everyone will be afford it. It doesn't happen that way.
No, but the way some of the hospitals also work, the minute they find out you have insurance, I mean,
Yes.
The rates completely change.
Massive.
And that's also not
They're
not
working
fair.
like hotels. You can't go to a hospital before the patient gets a bed. The reception has a
Exactly.
package ready for you. Would you like package A,
Exactly.
B, or C?
And whether you are
they're
covered
willing-
by insurance.
Yeah. So if you're covered by insurance, the that package moves, you know, what is your problem? Just
Like
take the...
five-
And I think
times
that
more.
also kind of tilts the entire cost grid because
Totally.
because then you're pricing for every single thing, every single product that they use, you know, during the treatment, to the process itself, to the charges, additional charges, the bed cost, IV cost,
The gloves and the, you know, the
If
mask,
anybody ever
everything,
goes
yeah.
through an actual surgical, the checkout or the report that you get,
Yeah.
Yes.
it's actually a very fascinating process
go
to see
through it.
how many gauzes are used, and you have no way of verifying any of this, by the
yeah,
way.
yeah.
But still, I'm just saying that because you have insurance or you don't have insurance, I understand that hospitals are also a business, but there are many businesses the government, as we were talking the other, has no business being in.
That's right.
And it's time for them to get out of the business. They've had a bad run with airlines, you know, and these are businesses they need to get out. One business the government needs to get in with all feet and all hands at this point is healthcare.
So my question would have been that how do you tackle the problem of high costs for private healthcare? The usual dilemma for any Indian is that government hospitals are not good enough in most places and private are not affordable. So would you agree with what Anupriya is saying, that the solution to that is just to improve the government healthcare, or is there something else we can look at?
No, absolutely, and more certainly that healthcare from the private side are A class. I mean, many people travel here for stenting or for most of their complicated procedures is because, you know, we have medical experts who are really world class. So there's no doubt. Now, how does this cross, fusion happen between the private healthcare and the government hospitals? And not to be like unfair to the government hospitals, you know, the KEMs and the NIRs of the world actually were able to manage the flow because, you know, unlike private hospitals, they cannot really say, tell the patient that you cannot
They
come
can't
in
say
here.
no. They can't say no. It's the basic rule. They
so
can't say no.
with those constraints and limitations,
Yes.
we still managed it pretty well. So
Yes.
to be fair to that point, only problem is that, you know, because I read a Indian Express article written by Nachiket Moore. He said, you know, it's about allocation.
Yes.
Are you allocating it in the right way? Have you been able to point the loopholes, or it's just a blanket, you know, approval of XYZ 1,000 crore? You know, if we are actually focusing it on the right places, then I think a lot of these things can improve.
Yeah, so that ties back to what when I was talking about how the states then play a bigger role. And I have a question, Vinay. Do you think that now the center, with the way they've handled the entire lockdown and the unlocking phase, and as it progressed, we saw more and more power being given out to the states. So center also realized that we can't do this without the states. Do you think that is going to be sort of some sort of benchmark as they see and say that, okay, in healthcare, we do need the states to sort of, step in more and sort of proceed in that format?
Yeah, I hope so. Look, I mean, in the current crisis of COVID, the situation was different because the government was using the National Disaster Management Act to implement laws, which of course supersede any other state law. So there was a technical procedural reason for why the ICMR and the Ministry of Health at the center were taking all the calls. Now that NDMA Act will no longer be enforced, which means the states will have far more freedom to do what they want to with their basic healthcare. But what I do believe is that increasingly the central government needs to realize that there are issues that we have, fundamental issues that we have, for which the cooperation between the center and the state has to be stepped up. It can't be about political hostility.
Yes.
Unfortunately, budget exercises are allocation exercises, but they're also political exercises. Allocations are done on political grounds.
Absolutely.
Several ministries' allocations for the longest time have been done on political grounds. I mean, it's only now that we see, thank God, railway budget has been merged into the national budget. But every railway minister would come and issue 10 new trains for their state. That's all that happened. So it's a political paper.
Why
But
does
they were
announcing
entertaining
trains,
speeches. But they were entertaining
Well,
speeches.
that was, yes, some, yes.
You have to miss some part of those entertaining speeches.
But why does announcing 10 trains carry so much more political weight than announcing 10 good hospitals in your city, or affordable medicines, or a scheme, insurance scheme
Because we've
that
never had
helps
a
you?
flashy health minister of political importance. You've had far more flashy
you've not had
railway
a
There's a
ministers.
cultural
Pandemic.
reason for that. I am a very strong believer of why that's a. You know, it's not something that anyone here in this floor will possibly realize it, because we are actually not the actual sample of Bharat. This is a very rarefied group. You step into a smaller town and you'll realize Indians are temperamentally fatalistic. And when they fall ill
Yeah.
or something goes wrong, they tend to blame fate, not that there was bad infrastructure next to you, which would have saved you.
Yeah.
That's true.
Far too
Yeah.
less people complain about it. You know, you see, to go to people in states like Bihar or UP in small towns, those hospitals they're not complaining about. There should be a protest of those hospitals. There are dogs and there are pigs and there are stretchers are not available. Nobody protests because they just tend to accept it as fate. This is no longer about fate, and I hope that this pandemic realizes and teaches people that.
Yeah, I think for anything to improve in this country, it has to become some kind of political fodder or tell you that you will get some political gains. Otherwise, it may be a great statement of intent, like you said,
Yeah.
on paper. But is there enough will to follow it up and actually implement it on ground? I think for this government, two big tests. One is the Ayushman Bharat scheme, as we've been saying, and the other, of course, is the follow-up on COVID and vaccines and the vaccination drive and how quickly they make it accessible to everybody. But before we go further with the cost conversation, Vikas, I wanted to ask you this. When it comes to India as the global pharmacy hub, do you see government making a lot more of announcements and taking steps to leverage this COVID pandemic to say we are the ones who are making half the vaccines in the world,
Yes.
and we're the ones who have the wherewithal, the knowledge, the skills,
Absolutely.
and so we call the shots. How do you see this panning?
So this has been a very big ground for the government to kind of reinforce its relationships with the rest of the world in terms of the vaccine diplomacy that we've seen. I mean, the same was followed in the healthcare diplomacy. Somehow hydroxychloroquine didn't work, so it got fizzled out. But in terms of supplying medicines to the rest of the world, I mean, imagine in the richer countries. I'll just give an example of Zolgensma, which is a spinal muscular atrophy drug by Novartis. One shot, and it's a one and done. I mean, it actually cures with one injection. Imagine, take a guess how much it will be. 16 crore rupees.
16 crore rupees
for one injection.
Wow.
And this
Okay.
is for what? What illness?
This is spinal muscular atrophy. This is a degenerative condition which actually comes from 5-6 months.
16 crores.
Yes. So thank God that we have the generic industry thriving here.
Yeah.
I mean, of course, these are extremely complicated products, so it will take like ages to master these. But for rest of the world, I mean, cancer also. I mean, cancer therapies are becoming so much more expensive.
Yeah.
So that's what I don't understand, that if we are the generic hub, and I mean, you've got the APIs coming out of here, why is medicines, why is pharmaceuticals still so expensive in India?
That's the point. So while we actually are supplying low-cost medicines to the rest of the world, we haven't actually done a deeper introspection of the market dynamics here.
Okay.
I mean, yeah. So Jan Aushadhi, a product which will be available for 2 rupees a tablet.
Yeah.
You go to the branded generic,
It's
it will be
10 times.
45, 50
That's
rupees
right.
per
Oh, yeah,
tablet.
absolutely.
And you'll see this in
Yeah.
CGHS, because you'll have a private doctor write out, you've gone to a private doctor, for example, and you've taken a medicine, and the doctor looks at it and says, I'm not going to give you this, and he crosses it out.
Yeah.
And
Gives
it's
you a
exactly,
different-
it's a
And
same
they-
chemical.
Yeah,
and
absolutely.
it's maybe 1/10 the cost.
And very few people know about Jan Aushadhi.
Yeah,
Very low awareness.
very low.
No, but why does it happen?
So branded generics is like you have to promote it to the doctor, the medical rep has to go. Here it's a generic. You don't have to do anything. It will be kind of placed.
So effectively, you get prescribed the medicine for which somebody is promoting that to the doctor.
Exactly.
And that's why they're prescribing you that. It may not be the most reasonable one in the
It's got
market.
the branding. It's
you
got a
have
thappa.
Affordable one.
Exactly.
It's got
You
the
have the
thappa.
same product available in Jan Aushadhi.
Yeah.
The same efficacy, the same potency, everything will be the same.
Yeah.
So, I mean, who will remove all these? And that's why, when there is
But
a
not
drug...
very many people know about
They
Jan
don't know about
Aushadhi.
this.
Yeah, I was,
Not
yeah.
very many
Jan
people
Aushadhi,
know.
very low awareness. That's my
Yeah.
big problem. I don't know why people
So
should
it's
not
a
be told
huge
about
opportunity which is actually getting completely
it.
squandered away.
Yeah.
So does the government really then need to think about not just spending money on more infrastructure and education, but just spending more money on awareness of the right kind of things, of reaching out
Absolutely.
Yeah,
on
they should.
awareness, even on insurance, for example. You've got the programs in place. let's get it rolling at least now. So I mean,
Yeah, but
that's
we're
the
talking
problem.
about Jan Aushadhi. There also you have then doctors who are, tied up with certain companies, and then they prescribe the drugs only of those companies, even if there's a cheaper version available. So all those nexus, that is still existing,
happens.
and it really sort of ends up
Intellectual
paying.
corruption.
Yeah.
So I have ended up doing it not for the most serious of issues that you get prescribed medicines for, but otherwise go to the pharmacist and ask him that are there other
Is this-
generic
yes.
options available for these medicines, and obviously the pharmacists are also equally well aware and well trained in this.
But that's the thing. In India, the pharmacist, actually anybody can be a pharmacist. Technically not, but mostly it's the guy who was used to taking out the medicine will now tell you. And you're right, he's very well aware. But again, coming back to educating and filling up the
Correct.
gap, your off-the-shelf medication should be able to, a person should be able to go and get it. Like my maid is getting a headache, she doesn't need to get to KEM to get probably a saline injection and say, Didi, main theek ho gayi. She should be able to go to a trained pharmacist and describe out basic symptoms which don't require a detailed prevention act to go to a hospital at some point. But we don't have that.
That's
We
where
just don't
actually
have
the
it.
US costs have gone up so much. I mean, they have a thriving innovative industry there, but because of this formulary kind of a setup that you actually have to go through all of these tests,
Before
no
you-
matter even if it is a minor headache,
Yeah.
you have to do these tests, and that actually inflates their numbers. Of course, the pricing is completely free, so you can actually, so there is the market dynamics plays only in the generic industry, and that's why our generic industry has also done very well in the US.
So that is also something that the government should look at. Awareness, or bringing about more awareness for schemes that are there and ensuring a wider coverage of the schemes which are present. We've touched upon it briefly here and there, but that's because it's so important, Avni, which is the insurance part of it. What is, according to everybody that you interact with, what's the biggest challenge there? Is just lack of awareness, or is there some other kind of hesitancy to say, why do I need it? Do I really need it? I can manage it. Why is the penetration so low?
I think it's a combination of everything, because if you look at, I don't know how many of you have actually pulled out your health insurance policy and tried to read it. It's impossible to decipher the what is...
Every time the brochure comes, I just sling it to one side, keep the card with me, and that's that.
But people don't even ask questions. People don't ask questions on critical care.
No.
People don't ask on disability. People don't ask questions on pre-existing conditions.
And the other big issue is that most people, I mean, all of us, at least who are salaried class, end up being covered by our employers. So you don't think it's necessary to have your own personal policy. But again, that's such a big mistake. I mean, especially in this day and age, you don't know when you can lose your job. So you have to have that personal health policy as well. So I think it's a combination of all this that the penetration is so low in India today.
Yeah, I know. I think it's actually, for me, salaried class is not the worry at all, because no matter how much we add up, it will still be about 10-12% of India, right? Any family, ask any family in this country, 60 to 70% of their medical expense will be out of pocket.
Yeah.
And that's
least, if
actually,
not
that
more.
is a WHO study. About 67% in India is out of pocket versus 18% of the world average.
Absolutely.
Yes.
So imagine how bad we are. I mean, it shouldn't really be a burden.
But we put so much of our money culturally into life insurance and LIC policies all the time.
Why? Because
but we,
no.
We
Because
don't do it for while living.
It's a cultural problem. That is a cultural issue. Ki I have to leave
LIC
something
policy
behind.
limit.
LIC policy. It's a cultural, and the ads have worked. Whoever did the branding for LIC back
Should
in
be
the day,
hired by
did
the
really
health
well.
department.
They should move to the awareness.
And extra LIC policy also means that you had a very strong-willed dad who will force you to buy an LIC policy because they don't believe any of the modern mutual funds or other things.
Or you know somebody who's selling
somebody
policies.
who's an agent, yes.
No, but sorry, going back to what Avni was saying, that I was going through some figures, and maybe Vikas can back this up, that I spoke to an insurer who said, people are saying health insurance has shot up in April to September.
Yes, it did.
It did, but it's only for group employees. So health
individuals
individuals,
also.
but individuals also, if you look at across the board, who are the people have topped up their insurance. People have topped up because suddenly you realize
that you need more.
That I will need, you're young and you're like, I don't need so much. You realize that each day, God forbidding, in an ICU suddenly cost you. These were not realistic numbers for anybody.
Yeah.
So people have topped it up. But still, group insurance as Avni was saying, people don't take personal insurance. You could lose your job. Secondly, when you ultimately leave your job because you know you want to go to farming at some point, and you leave your job, you realize that 60 the premium or 50 that the premium you're going to pay to take on a new policy is insane.
Why should insurance attract 18% GST? It's not part of the budget, but still.
It definitely should. It just cannot. It's one of the essentials, and
It's
it should
18%,
not.
no?
And that is one of the biggest demands of the industry, that remove this 18%, 5%, 6%.
But again, the budget can't do anything about
the
that.
need
correct.
for-
Again, the budget can't do anything.
So it can
Yeah, yeah.
intent.
So the
Budget
need
can
for-
give intent.
need
We will
for
take it to the
insurance
GST
will
Council.
become very important now because you know we are already being known as the diabetes capital of the world, and there will be a diabetes tsunami. Now, once you've got that, there will be so many more comorbidities like cardiac, and you know it's no longer a urban issue now.
Yeah.
As we move into this affluence and more income, it will become a rural issue also. And there, if you actually have a health episode, it can be really debilitating. So to have an insurance widely scattered, how they want to do it is a complex issue again. But I think it will be very important to have health for all covered. That
So
should be.
should it be a nationwide scheme
Yes.
covering a larger percentage of
it
people?
should be a fundamental right.
Correct me if I'm wrong, Vikas, but in Europe, I think it's mandatory. Every citizen has to get it.
Absolutely.
Like most countries in
But,
Europe.
but,
Absolutely.
but
Oh, the
I mean,
entire
I'm not
Commonwealth.
saying
Yes,
good
the
or
entire
bad.
Commonwealth.
I'm not saying good or
Entire
bad.
Commonwealth.
But this government does believe that the middle class should do its bit in terms of contributing to nation building. So I don't think that idea that let's give them some kind of a setup covered insurance scheme is going to work. They will, I mean, for a country our size, even if you get the lower class and the lower middle class covered,
Even if it is a 10 crore into 5, I mean, considering it will be the 50 crore, I think that will be covering the base of the pyramid quite well.
Yeah.
And then it can actually keep moving up. But at this stage, it is so important to have maximum coverage because otherwise, you know, this burden of stroke, heart, diabetes, these things are going to be
Correct.
massive. And leave that. I mean, we don't even talk about infectious diseases. I mean, this
We're
virus
not
will...
about the one-off. We're talking
Yeah.
about the things that you're definitely going to get
Yeah,
at
so
some
it
point.
is called as a double blow, you know, it's a double whammy.
Yeah.
that
And there's
you
one issue that I wanted to again ask Vikas about because I'm really keen to know what his view is. I also believe, I mean, it's not a union budget exercise, but it's something that I almost am imploring India's private sector. The part of the problem for me at least, and I'm reacting purely as an individual right now, is that a lot of the private sector in healthcare is doing this 5-star hotel approach and frill-based development of hospitals.
yes.
If you see in many states in India, some
The
of the most
airports
trusted
and the hospitals are getting fancier and fancier than
Some of the
five-star
most-
hotels.
In certain states, some of the most trusted hospitals are the charitable hospitals.
Yes.
Yeah.
Because they are not doing frills. They are just expanding
Basics.
the base of the number of people they're covering.
Yeah.
Why shouldn't the private sector do that? I mean, I don't need a theater in a hospital.
But,
and I know there are
but
hospitals
how do you
with theaters in
dictate
it.
that, Vinay? Because at the end of the day, they're also going to make money. They're going to figure out ways to, cater to a certain segment of people
Exactly.
and just
The
make
bane
money
of
there.
capitalism.
Yeah, P&L.
I mean, at the end of the day, then it comes down to that argument that if you're going to privatize it, then they're going to find ways of, adding luxurious layers
But then
and charging
you
more.
can do it on both ends. At no point do you say that you're only doing that. I think the point Vinay is making that they're only focusing on that. They're not expanding that reach. I'll give you an example. I was very pleasantly surprised in the last 4 years in Bombay. There's a new children's hospital that has opened up, and it's fantastic. It's really fantastic. And if you go there, you'll realize you'll have people from all walks of
Government?
all walks of
Private.
privately held. It has a lot of NGO backing as well, has a lot of CSR funding as well coming in as well for some of its emergency wards and all. But they're dealing with the across the board economic strata, and I've seen it that the costing is different for them as it is for me to see a pediatrician and it's only pediatric specialty. So I'm just saying they have the opportunity based on whatever measurements they can to charge a certain section of society who's willing to pay for it and keep those services separate and be mandated as you've done it to some extent with education and RT, right to
But
education
it is
Act.
mandated, isn't
It
it,
is. It
Vikas?
is on
But
paper.
they
It
just
is.
find
Yes,
different
they-
ways
on
of
paper.
occupying those beds.
Circumventing it, exactly.
But they circumvent it because there's no
Yes.
surveillance as
Yes.
Vikas. So, I mean, it has to be that you can have your seaside bed and you can charge people the earth and the moon for a delivery. But at the same time, you should be able to provide a basic ambulance service for a man dying on the road, which is not available in India, by the way.
Absolutely.
And when the ambulance arrives, it does not have a trained paramedic inside it. So the number of mishaps that happen, especially in traffic conditions like Bombay, because the person sitting with you in the ambulance is not trained. It's just not trained. So these are the gaps that have to be filled now before a next hospital comes up.
And even before we announce another, say, health insurance scheme by the government, there already are a few in place, because we don't even have the data as to how many people have actually put in claims and how many have got those claims and why they haven't got. I would like to see that data, because there's no point in announcing all these schemes if the person doesn't know they're eligible, if the person goes to a public hospital and it's a complete mess, nobody has the time or the bandwidth to understand what you're covered under. There's no point unless you can actually see the whole thing through.
True. Very
No,
true.
but I'll give you an example. You recall the MR vaccination drive that took place, where they did that MR all through Maharashtra. They did a MR vaccination. All school children got it.
Yeah.
They had the database for it. They had the follow-ups for it. They had the doctors for it. So it's not like there has to be will to do it. It was very clear from that vaccine drive. From day one till day end, every single child enrolled in school got
covered.
vaccinated.
Just for the viewers' benefit, it's measles and rubella. That's
Yeah, MR, measles and rubella.
just in case.
And it was a free vaccination. They were BMC workers, which comes back to again state. At some point, center will have to ask states if not,
exactly,
that dynamic has to change for this to happen. It cannot be a new India, it cannot be new health without the state stepping in.
Before we wrap this up, the one final question I wanted to ask was about, again, the vaccine and the COVID vaccine. The first few weeks have showed us that there is still a lot of hesitancy, some of it justifiably so, because like you said, the data isn't out yet, complete transparency isn't there, and questions are being asked. Some of it because it's the unknown. People don't know. Adults have never taken a vaccine. So it's just a very strange alien concept to many people. They don't want to take that risk. Is it likely that the government addresses, one, the funding of the vaccine drive? Where will they get the money from? And two, also speak about, what role people will have to play, paying for it, a special cess, or the salaried class, or the states. Is that something that should get addressed in the budget?
So, for sure, I think, it's from the time, Adar Poonawalla mentioned about the famous tweet about 70,000 crore and how will the government actually mobilize that fund. This came up that, there probably will be a need for cess. And though the government has actually made statements that they are able to handle it well on their own resources, but it looks like a cess will be coming up.
Go ahead.
And secondly, I think for the ones who will be at the lower end of the income curve, I think for them there will be subsidized rates for sure. And then more or less after the first batch of people are covered, I think it will be openly available in the free market.
But you see the costs coming down? Because, so for example, of course, the government is procuring the Covishield at about 200 rupees per dose. But Adar Poonawalla has made it very clear that if he's going to put it out in the market,
it will
be
about
1,000 rupees. If you're saying 1,000 rupees for a family of 5 people, that's 5,000 rupees. It's not going to.
But you know what?
And 2 doses, that's 10,000 rupees. We in India, in our country, people don't want the gas cylinder because they're not going to be paying 800 rupees, let alone 10,000 rupees. So that will become a big challenge if the center plus the states don't come in and say, okay, we share this burden.
But I think that will get divided. That will be an income division, Tanvi. So there's no way that the person with the ration card is paying 1,000 rupees.
Correct.
They are going to vaccinate them. After that, a lot of corporates will set in. I want to call my employees back. I want to show, you have to show me that you are COVID, and I will get it done. People will need people to travel again. Many countries will not let you enter or even get a visa, and many are desperate to go without showing that thing. So these compulsions, especially on the top 1%, 1,000, I mean, that's what happened with testing, right? Where did testing start from from 4,500, 2,400 down
Yeah.
to 750. So, I mean,
650,
it
yeah.
takes time.
Yeah, of course, the
And remember,
top.
this is just the cost of the vaccine. We are not talking about
The
the hospital.
logistical
No, the
cost.
charges that the hospital will also
Oh,
take,
yeah,
right?
yeah,
I mean,
Yeah.
so,
So there's some interesting ideas that I was reading about of how this can. One of them is cross-subsidizing. So you allow vaccines even from outside to enter India. Let people who can pay for it whatever their rates are, and then make sure that you use that money to subsidize those who actually need it. So this is, I mean, COVID cess is one thing. This is another idea that I
So
found
the government
interesting as
taxes
well.
a Pfizer or
and
a
add
Moderna
cess or
vaccine.
exactly, and add a surcharge on those vaccines.
I just have one point. I mean, all very fine points. Just one point which is slightly different, which I want to add is this, that I do hope that this process of mass vaccination does not become a political exercise, because the states get into this battle to provide free vaccine. It's a bad idea. Those who can afford it should pay for it.
I
Because
completely agree.
ultimately, you're going to add a burden to the exchequer,
Yes.
which needs money for those people. So it shouldn't become an election promise on the manifesto at all. Of
So the
course,
West Bengal and Tamil Nadu will
Yes,
probably end up giving
absolutely.
it for free.
No, the government must give it to free to those who want it,
Yes.
or those who need it.
Yeah,
need it.
yeah,
But the rest
yeah.
of them
Those
should be
who
paying
can't
for it.
afford it.
The BPL, the ration
should
card
be given
holders,
it. They should be
people
given
who are
it,
still
yeah.
who are availing grain from the government
They should
have
get
to
it
get
free.
the.
Absolutely.
But if you are paying tax in any
You
way,
need to pay for it.
if you're filing for tax, I'm not included in that. Should get it for free. Should get it for free.
Okay, on that note, thank you so much to everybody for joining us on this conversation. We've tried to cover all aspects of it, because we here in Mirror also genuinely believe that healthcare is one of those sectors that needs dire, urgent attention. And if this realization doesn't come to us after having gone through the pandemic and come up with 1,000 temporary solutions to deal with it, then when will we? And when will we begin to bring about the change? Thank you so much for joining us.